I'm not so sure. I'm the clinicians, private practitioners in Bangkok, Thailand. Anytime that you would like to see the night scene, natural scene, or cultural scene, welcome to Bangkok, Thailand. Now I would like to change your mood a bit because I'm private practitioner that see the patient starting from the zero to the end. I work with your surgery and prosthodontics. Is there anyone in this room work both of fields? Just only two guys. And other ones? Oh, okay. So please follow me track by tracks. I have three words for my story. Firstly, stability tip. Second, CMI protocol. Third one, Anycheck. Three keywords, okay? In the past, because I have been trained in the implant dentistry since 1999, I have to remind that how is the bone density in my mouth? D2, D1, D3 something. But we knew that bone density is the key for implant placement in the beginning. But just only get in memory that, okay, I have to get a good stability, 30 Newton cent, 35 Newton cent, but if we can get a good stable, we can do something further. If we cannot, just only if course all the times. So I keep in mind that with one box set or surgical box set in different bone density in different area of the mouth, should we use like the same drilling protocol and one diameters of implants? I don't think so, because we knew that the bone density in each area is different. So we will have two choices, too low or too high. But I do not understand well how to control that. I got some failure, but Dr. Homle Wang, this is my respected instructor that I start to do training with ICUI program. So Dr. Homle Wang and his team launched this paper 2009. Within 2 months, they placed 4 implants in. Some lost, and all got bone loss. So the highlight is unusual implant failure. They use the words unusual implant failures occur as a result of over compressions of the bone. I never knew that. I would claim to another one that, wow, my implant is quite stable. I'm a big guy, but I cannot move it down. But another story that we have to learn more. So the company tried to reduce or eliminate this problem. But what is the great way to do, not use if course, but put the implants in, and I can do further? That is my idea that I would like to follow this track. So this concept show the picture is quite clear. They use like the countersink, or somebody use like the cortical drill. Just only enlarge the cortical area. But they can minimize the overcompressions, but it doesn't mean that they confirm for your implant stability to do the further step. I think this paper from ICUI journal from neobatic teams is quite clear and important for my mind to set up, because this article showing 3 models. They did with the implant diameter 4 by 10, and they use starting the first drilling, not to the final drilling. Maybe the step of drilling are the same. The difference is the final burr. The final burr is mean, if you take a look here, with this, they study in the model with like the thin crescent bone. And this one, this is the crescent-cortical bone with just only underside drilling. What does it mean? With the neobatic protocol, if you use diameter of implant 4.0, the final drill burr is 3.5. This is like the undersize, making the hole smaller than the size of the implants. But the second one, they use the colonal widening with the cortical drill to minimize overcompressions. But the third one, they use the cortical tap to make a thread. surrounded the crestal bone inside. You can see the number. It's different, just only the final burr. So if we make it in the thin 1 millimeters of cortical bone, we can see that if we use the drilling protocol plus cortical tap, you can get the base value of torque. So this show around 35 Newton-cent. But if you use the cortical deal, it's dropped down to be 12. But just only undersized filling, nothing to do on the top. It's overpressure. It's amazing. Just only final deal that you make decision. But with 1 millimeters of cortical bone, imagine such as like a porcelain maxilla, you can see that nothing to do on the cortical bone, you can get the best value of torque. So with this matter, and I follow the track with Dr. Whole bone density classification with his textbook, I will follow this to tell you and change some idea about to do evaluation of the bone density. It means you can make your own decision. When you drill, you separate in 3 parts. 3 parts of implant link. Separate in 3 parts. On the top, we use C, crestal. M on the middle, and I, this is the inferior or apical. You make your sense and check that. How is the bone density? And you can use the words. If it's hard, you divide in 2 terms. D1, hardest, and D2, hard. And if it's soft, you divide in 2 terms. D3 and D4, soft and softer. That's all. So if we plan to do the drilling, maybe you can write it in your chart. Like, this one, C1, M3, I3. What does it mean? C1 is mean you feel that on the top crestal, in the beginning you first start to drill, it's quite hardest. And when you penetrate the cortical area to the middle part and inferior part, it's quite soft. Something like this. When you remind that, okay, how is your bone density for your own implant each by each? That's a way that you can design your drilling protocol. Wow. It's like the real answer to do in the reality. So my point is, if we can control the stability depth that the first session talked a lot with this, so we can do anything. But the key is, I think I had some conversation or including like listen to like the implant dentist opinions. We can say they're brave to touch the immediate loading. They're brave to touch the conventional loading, but they still avoid to touch early loading phase. So that's the key is stability depth examination is my job. So I have 2 protocols. The details I will give you in my lectures, 11:20, that's right. So easy to remember. In the cortical area, even though along the body of M and I, in some cases, example like a lower anterior, if you find that this is a hard bone, hardest or hard, you think that you have to do the tapping for making the tap relieve your overcompressions, and you can get the BIC better. But if you think that it's soft or softest, you can think that, okay, this zone, maybe we can do underside drilling. What is the meaning of underside drilling too? Underside drilling is mean you make this hole smaller than the implant size. The protocol provides such as like a 4.0, the final drill is 3.5. But it's too soft. You can reduce the diameter to be final deal with 3.0, and you can jump the implant placement in. Now, the way that I will tell you by this picture, so we can design, see if we would like to have the cortical stability. Second, M and I. In some cases that we need to have a great cancellous stability, we can do undersized dealing or under diameters. So with this taper apex implant, they will penetrate the bone and cutting the bone and making your cancellous bone push to a side So the way that we can finally, after implant placement, is the surrounded bone density around the implants is denser than before. Another thing is, in some areas such as it's quite clear to show the example of sinus cortical flow. Nowadays, the instruments such as like a SCA kit can do cortical flow preparation. So it means you can get bicortical engagement, even though this is a short implant. The last thing is avoiding overpressure necrosis that Dr. Homlewang presented in 2009. That is a total key that we can do predictable primary stability and avoiding overpressure necrosis. I did a lot of immediate loading. I bought some appliance to check the initial stability at my surgical day. But I never did along the way that I'm waiting. So when I use Anycheck, it's quite simple, easy, because example, if you put the implants in and you did with the non-submerged implantation, you connect with the healing abutments, there's no need to put another tools to connect with your implants. You don't need to take the healing abutment off and put something in for checking. So you can check with the patients that you use this instrument to do tapping. With this tapping, it can show the result as the famous instrument before, but some key is, when they got the tapping, they will show the number. Good to see it, you can see the green light. It means that this implant has passed the examination. But as you can see, the red light is failed. It means that you have to wait. If you see the yellow light, like you drive the car, you have to slow. So, with another height of healing abutment in each situation, you can use this key to plus and minus, okay, your IST value compared with the standard healing abutment with 4 millimeters. Maybe this is a short example that I would like to show. I tap with this. Maybe we cannot hear the sound, but this instrument will help you too. Example, if your implant got a good osseointegration, they will hit many times, 6 times. But if your implant is not good integration, they just only hit 2. It means don't touch it more. Okay? Now with the surface, because with the, how can I say, nowadays we concern implant design, surface treatment, including drilling protocol. I just present drilling protocol. But with the surface treatment, I start to try with the plasma treatment machines. Easy to say, just only open the cork off and placing down in the machine, 60 to 90 seconds. This machine will use the reactivated gas for make your implant love the blood. Okay, no times. Okay, so I will do quickly because this is a case, okay, that I did. You can see the IST value is, you can see, not less than 65. And this is the example that I did with the real cases. I put 2 implants in, okay, with the bone graft, did with the non-submerged implantation, and I observed along the way in 2 weeks interval, we can see the great crystal bone, and this is the result of the IST check. If you got more than 65, it means that the integration is passed. And I did it, it means after 6 weeks, the graft is good of IST, so I take impression at the 6 week, and in the next few days, I put the insertion. I have the last example. Normally, if I have 3 implants and I can control a good stable, I will do with the 3 implant placement, even though on the label bone is thin a bit. But we can do bone grafting, and I do scanning, and I put the temporary teeth after a few days. I think every treatment many people did with this, but I would like to check. So I check with the X-ray in 2 weeks interval, and I connect with the temporary, so I change the tapping to the temporary and compare to. So everything was done with a good result like this. So after 6 weeks, we can get an 8D. So that's why we did the impression after 6 weeks, and do final impression. So I think maybe it's too quick at the last period, but mission complete. So I'm done.
Great.
Thank you.
Well, my friend, first of all, congratulations for your presentation, your cases, and your experience. It's great.
Thanks.
I have a message for you. I have different bone densities should be used with different protocols. We have to give more importance to this concept in all our practice. My question for you is, what factors in your own experience do you think could affect the decrease in the value of the IST, specifically or not in the post-extraction technique with immediate loading placement?
Oh, thank you, Dr. Edgar. It's a great question. I have some idea with this. Dr. Edgar asked me that if we have to do the post-extraction implant treatment, take the tooth out, put the implants in, how is the effect for my treatment procedure to IST? I would like to say something like this. I would like to separate CMI protocol, IST value, and any loading concept planning are set in 3 parts. Firstly, with nice case of Dr. Edgar, he did a lot of immediate implant placement. So he has to plan how to achieve the great primary stability in the beginning. If he can get it, maybe many articles told us maybe in decades that we can do the provisional laceration, but keep in caution that not loading. I would like to say something more. If we have to plan with anytime loading concept, one more thing add with Dr. He concept that if you can get primary stability more than maybe 35 or 40s, the other thing is you should have C fixation also. What does it mean? Your implant should have cortical stabilization. That's why in the beginning that Dr. Jeffrey mentioned about, he preferred to work in the native bone or the heel bone side.
Yes.
So it means if take the tooth out, answer your question, you put the implants in, IST value can be great. It means you can get maybe 75, 85, but without C fixation or crestal bone to support, I don't think you can do anytime loadings. But with the effect of the IST value, maybe I'm not so sure that how is the safety of your temporary laceration. If you have multiple, you need to do splinting. Some has C fixation, some has not, it's fine. But just only single crown, keep in caution that tell the patients do not use it, just only smiling. Maybe this is my answer, doctor.
Thank you. Wonderful.
Yeah.
Thank you.
Great point, and thanks.
Yes.
Because, CMI fixation, the most important fixation is from the C fixation, right? Because, when you get the C fixation, we have a shorter crown length that allow the more resistance to the lateral force. If we have a long crown, with the same lateral force, more force is applied to the implant because the apical fixation is more longer crown, right? It is jeopardized for single implant loading. So it's a good point. So how do we solve the problem? We connect all implant together, the spring to all implant together. So if it's multiple implant, right?
Should be sprinted, doctor, I think so.
Right? Yeah?
Yes. But some cases that the C, maybe we can see like the absent C or absent M. It's mean like such as the long natural root of your front teeth. You can get just only apical fixation, and we did with a multiple unit, example with a full R. Sometimes we can leave it. But I think with the Dr. Paulo Malo lays the concept on for one thing that the cross-arc stabilization, including like I use the acrylic material to be the soft cushion. Maybe this is helpful. That's why we cannot do the final laceration in the beginning.
Yeah, but in the upper anterior tooth, after extractions, we need a restoration, even if it's single crown and lack of CM fixation, right? But still, we have a good success rate in the immediate placement in the anterior region. So the key is, we out of the occlusion, right? With just restoration, but free of occlusion, right? So we have to be
Yes.
very careful
Yes.
when you do the restoration in the anterior region. So a lot of lateral force is applied, so we have to get rid of it, right? And the lateral force. But still, we need to do immediate
Yes.
placement and loading in the anterior region, right? So
For the forces,
we have to be
yes.
very careful for
Very
that.
careful for that.
It's a great thing. And when you check the stability and at the day of surgery, and the 2 weeks later and 4 weeks,
2 weeks interval.
2 weeks
doctor.
and 4 weeks,
Yes.
and what is your conclusion? Is there any stability dip or not?
I would say like this. This is a highlight. I got a big surprise when I did this clinical data. So finally, we can say that if we can control the stability dip or maintain the dip, it means that your IST can be dropped a little bit or maintained, especially in the second week. In the second week, maybe in some case, it can be slowly increasing until the 4th week. But I'll give you advice like this with my experience. When you use this Anycheck, maybe you have to tapping in the proper axis because the number can be shown. At least you should tap maybe few times to do the leg cord and
Yes.
making in the avalanche. What is your stability there? But with my result, doctor, I can find that my graph, we can confirm that for myself. I can control the stability dip.
Stability dip.
The stability dip can be eliminated.
Okay, sure. So the first step for the anytime loading is to confirm there's no stability dip at all, or just minimize the stability dip after you place implants. So you have to check, or you have to measure the stability from the 0 day and until the 4 weeks. See that there's a little stability and increase the stability. So if it goes down, decrease the stability, and you have to wait until it increases the stability. And in over 70 IST value, then we can handle, we can touch, we can make impression. So that's the first step. We have to verify your placement, the protocol, and we have to make sure, okay, we can minimize the stability dip. The first things. When you verify that, and then now after that, I know there's no stability dip in my practice, so I can do anytime loading. Is that true?
Yes,
It's in your hands.
I agree.
Yes.
Right?
In your hands.
Do you agree?
Yes,
Okay,
totally agree.
Right.
Then you said that with the Anycheck, you could prove in your clinical practice that there are no stability dip.
Yes.
Then it could be a way to do a multi-center study without histological findings.
I told you about it. Please call me in. I would like to say like this. Why this point is interesting in our clinical routine practice? Because if you have the patients come to your clinics, one of the popular question is, Doc, when can I get my teeth?
My teeth.
When can I get my teeth? In the past, I would like to say, if I can get a good stability, I will do. But this technique is quite good because we can check the IST in the beginning. Example, if I start with 80, okay, more than 65 is past the examination. If I can get 80, maybe I can do impression taking at the surgical visit. But after second visit, maybe at the second visit after 2 weeks, if this one is dropped down a little bit, example 80 to be 75, maybe we can wait. And the 4th week or the 6th week, if the 4th week is coming up, sometimes I will put the crowns in. So it means that if we can check that along the way that during 2 weeks interval, the stability is not dropping down. We can control it. The restoration that we prepare, we can do insertion in. So that is a key that I think maybe this is a benefit for the patients and clinicians in the future, but they have to follow the good track too.
Okay, so we know the some device to measuring the stability. So what is that? Instrumental, right? Instrumental, everybody knows that. Instrumental. Can you measure the stability in 2 weeks? After 2 weeks, can you measure the stability with the instrumental?
It's risky.
This is very risky. Why?
Yes.
We have to
You have
take
to
it out
take
the
on the
healing
screw.
abutments and then connect the smart pack and then measure and remove it. But sometimes the implants come out.
And you apply your forces.
And with the smart pack, you remove the implant.
Yes.
So nobody wants to measure, you know. So nobody knows stability between 1 week to 2 months. So nobody wants to touch. You know, this is the time I tell you, I developed Anycheck, which means device for anytime loading. Anycheck. It can measure the stability anytime you want. So it becomes possible to determine the loading time after we measure stability. Every time you measure, it's over 70 IST value, then you can do everything. So that's the value of the Anycheck, right?
Yes.
Great.